Sorry, I was muted. My screen is visible to you guys?
It is.
Good.
All right, well, here's a good one that came in yesterday. This guy is a young guy, and it's a shame that David's not on here, but it's okay. Actually, he's not that young, but he presented to an outside hospital back in October at the time of this study, and you will see, as we have seen many times before, a profound centrilobular and really even tree and bud appearance. And it's very uniform, but there's nice sparing of the fissures and the pleura. You might argue that it's slightly more upper lobe predominant. There's a little bit of less involvement in the bases. You know, that's plus or minus. And so it could be small airways. We, of course, show lots of excipient lung. His right heart is normal. His pulmonary arteries are normal. And so, as has been brought up many times, most recently by David, I was going through this with a pulmonologist yesterday because he was consulted. And we were going through, and it turns out that this guy, right before this study, smoked, quote, a bad marijuana joint. And he has no idea what it was, if it was real marijuana or synthetic marijuana, but he ended up hospitalized with this. So I think this is another one of our little marijuana cases causing this diffuse inflammatory bronchiolitis in this case. And, you know, we don't have path on it, but he got a follow-up study the other day, and you can see that there are still some residual findings. I mean, this more looks almost like just a respiratory bronchiolitis like we'd see with smokers. What was interesting, though, a couple of things. He now has a little bit of eosinophilia. He has a couple of little bands of ground glass and little linear areas of consolidation here. So I don't know. He also has para-influenza at this time, so maybe he has a superimposed, just acute process. But this sounds pretty typical, or looks pretty typical, and his history fits with an exposure to some sort of bad inhalation. I don't know.
Yeah.
What do you guys think?
Definitely.
Yeah.
And
now,
maybe,
go ahead.
depending on what stuff is actually in synthetic marijuana, I suppose it's possible that you could have an eosinophilic reaction to something as well simultaneously, I suppose.
Right. Well, and there are reports of eosinophilic pneumonia from smoking and from smoking marijuana too. And like he said, they asked him again yesterday, and he doesn't know. It was a joint that was already rolled. He has no idea what was in it. So it could have been synthetic, but as he said, it was, quote, a bad joint. So, and obviously it did bad things to his lungs.
Yeah,
so,
for sure.
But I think this, my rule is when it's so diffuse like this, it's not just going to be an infectious bronchiolitis. And this is another one that proves that, I think. And then we can get to Jeff's. We can get to Jeff's rule here. This is an interesting one that I just saw this morning. I want people's thoughts on. This is, of course, a breast MR that was done yesterday, and you see in the right upper lobe there's all this T2 hyperintense stuff, and there's a few little air fluid levels, and looks like little bubbly things. And then also pay attention to this. We'll come back to that in a moment too. So they went to CT, and this was the CT I just saw within the last hour, and I'm curious what you guys think, because there's now fluid in these dilated cystic, what look like air spaces. And when you start to look at the airways, because of course the first thing I'm thinking about here is something congenital, either a CPAM or a bronchial atresia. Mm-hmm. The anterior segment of the right upper lobe is here. It does branch out here, but I don't know. There's not really any airways in this area. There's one little tiny focus of calcification. I don't know what to make of that. It doesn't really look like this is superimposed infection either. It just looks like fluid in these things. And of course, one congenital abnormality begets another, and here is this little, what looks like a foregut duplication cyst that has been there as well. And so this was all worked up way back in 2010 and before, when she was diagnosed with her breast cancer. And you'll see that all the fluid fill in these little spaces is new, but other than that, it looks pretty much unchanged. So do you guys have one favorite over the other, or is anybody going to argue like sequelae of infection? I guess I'm not crazy about that. That's what it would have been called way back here, and there's that little duplication cyst.
Travis, it doesn't have the typical CPAM look, sort of with the bubbly.
Yeah.
Yeah, I mean, unless some of those are cysts and not airways, but it looks more bronchial atresia. What's interesting is there's not a lot of hyperflucent lung distal to it.
I know. I mean, I still think it's congenital, especially given the presence of the other congenital lesion number 2. Yep. But I don't know. I mean, it's more of an academic point, and I think that, you know, especially with bronchial atresia, we sometimes see them fill with fluid and then lose the fluid and fill with air, and vice versa. So
yeah, I go for that combination too.
Okay, doesn't really bother me. I know we've talked about having like hybrids of sequestrations and bronchial atresia, and I can't remember, Howard, you had pulled up some pathology, some pediatric pathology paper a few years ago, right? Talking about these hybrid lesions. Wasn't that something you had discovered?
Right.
And did that include CPAMs as well, or, you know, other developmental abnormalities?
That particular one, well, there were two papers. That particular one really showed examples of sequestration and bronchial atresia together. And then the other point they made was that it seems like the airway abnormality, the atresias, seem to be common to all of these things.
Yeah. So,
yeah,
just a little bit of a curiosity there. And then this one's a quick one I sent out to a couple of you yesterday. And I think Seth's on there now, so he'll appreciate this since he has still the best example of this phenomenon in the aorta. This is a 92-year-old lady that came to or 91, came to the general yesterday after a ground level fall, and they did a little bit of a pan scan. And of course, this was seen right here. And the question was raised of a minimal aortic injury. She didn't really have much of a mechanism for it, or even a dissection flap. But when you look at it on routine windows, you see that the minimum attenuation in this thing is way up in the hundreds or 200s, and it's not, you know, there is no real discrete flap here, and it's along the undersurface of the aortic arch, just like that pseudo dissection case that Seth showed. There's a little bit more linear, wispy stuff further down. So I think that this is just another good case of aortic smoke from, you know, heterogeneous turbulent flow, and as David would say, you know, that in anything, you know, any tube or body of water, that the sediment usually collects along the lesser curve, you know, like in a river or something. And so this is, you know, and you have more flow out along the outer curve. So I think that explains why we see it here again, like we normally do. So I don't have the follow-up. They're not going to do a follow-up. I told them they don't need to do a follow-up, but that's what this is. But I think it's a good example not to get fooled again.
Oh, yep, definitely.
All right, Jeff, that's it for me for now.
All right, thanks, Travis. Let's see, Brett, you're on. You have any cases?
Okay. Yes, I do. Yeah. All right. Do you see a chest CT?
Yep.
All right. So this first case is of a gentleman in his 60s who has seen us a few times because he eventually went on to lung transplantation. I'll show you the post-lung transplantation in a second, but you can see that, you know, apropos of, I think, last week, there are these conglomerate masses here in the posterior upper lobes with areas of calcification. You can see that there is a lot of distortion and some traction. There's nodular interstitial thickening, nodular septal thickening, especially there in the left upper lobe. And this person is or was a stonemason and had worked you know, with stone masonry for a number of years, and this is a case of silicosis. You can see the peripherally calcified mediastinal and hilar enlarged lymph nodes there. And so you know, checked after last week's conference to see if there were any calcified lymph nodes in the abdomen, and there are none here. So but I'll be checking that on any other cases of silicosis that come in. But he went on to, that was interesting itself, but he went on to lung transplant.
Lung windows 1 second before you show us the inspan. Just,
yep.
Does he have parasecretrial emphysema or bronchiolitis?
He does, yes. So he does have, a lot of this is cicatricial emphysema up here from the fibrosis, from the progressive massive fibrosis that he has. So I thought.
I guess, yeah, I guess it should be that. And then quite a bit of pleural disease, not incidentally, but pleural thickening in the basal chest.
Right. There's a lot of pleural thickening here, and scan down.
Just quite a bit, huh? Not quite sure why. Okay.
All right, and so he went on to lung transplantation, and unfortunately, he kept working in the same setting in stonemasonry. So this CT shows an upper lobe predominant fibrosis. This is about 5 years after his lung transplant. And he was doing well for a while, but then he developed progressive restrictive PFTs. And you can see here that, we're not going to get rid of the calcified lymph nodes here and the mediastinum, but we're going to look at the lung windows here. And you can see that there's severe upper lobe symmetric fibrosis with traction bronchiectasis, and really there's not much aeration going on in the upper lobes here at all. So the question is, I would favor that this is and this is what we said, that it most likely represents a restrictive allograft syndrome in the setting of, of CLAD, of chronic lung allograft dysfunction. I didn't really see any, many or any recurrent nodules to suggest that this is all, again, recurrent silicosis, but presumably this is a case of restrictive allograft syndrome. Look at all that upper lobe fibrosis, just severe in the setting of lung transplantation. So just thought this is a really nice example of restrictive allograft syndrome, but it could have been recurrent silicosis because unfortunately he still works in stonemasonry. So,
Brett, when you argue though that there's not enough, it takes years to get that much lung injury for silicosis, that this is what, 5 years out?
Right.
That's probably,
based on that.
This is there are no background small nodules. This looks like classic PPFE and restrictive allograft.
Yeah, but at least, I just went through the thinking that I had when it popped up on my screen, and I thought, could this be recurrent? Because he is still working, but for all those reasons, it's not. We decided no, it couldn't be recurrent silicosis. So it's nice, classic restrictive allograft syndrome. So okay, I have a quick case here. I think Travis may like this case. So we have a lateral radiograph here in this person, I believe, who's in the mid 40s or early 50s, and see a nice huge something sitting here in these soft tissues. And I'm just showing this case because this is the largest particular one of these I've ever seen.
Wow.
Just massively enlarged, heterogeneous thyroid bilaterally, with some tracheal compression. Just the largest, presumptive goiter that I've ever seen in my life. So this has been going on for, I think the history was 4 years, and the physical exam record said, presence of golf ball sized masses in the neck, but I would argue that these are more football sized masses rather than golf ball sized masses. Here's the frontal scout. Let me get to that one. So you can see just massive, goiter presumably. So has anyone seen a larger one?
That's the largest. How old is this lady?
I've seen, in Western Maryland on the shore, or Eastern Maryland, there's this small community that supposedly has severe iodine deficiency. And we used to get them occasionally, and they would have stuff like this. But it was very interesting. It was localized to one small area of Eastern Shore. Don't ask me why.
Wow, interesting.
Yeah, I don't.
All right, here's another, on the theme of something else I just brought up here. This is a woman who is in her 60s, I believe, early 60s, and has the following CT. Has bilateral mediastinal and hilar lymph node enlargement, and the lungs look like this. Has bronchial retraction and peribronchivascular distortion, artificial distortion, really pronounced bronchiectasis in these regions. Some regions here in the lower lobes are very central around the peribronchivascular bundles. And so I would have been happy to call this, sarcoidosis. However, in looking at the history, she worked in a nuclear power plant for years, and she was actually responsible for cleaning some of the clothes from workers as they came out, and there was a lot of beryllium involved in this plant. So, not only is that very suggestive of beryllium exposure, she apparently had a positive, we don't have the results on hand here, but she had a positive beryllium lymphocyte activation assay, which I didn't really know too much about, but it can be very apparently specific for reaction to beryllium. So, presumably this is a case of berylliosis that looks like sarcoidosis, as is kind of the teaching that it can be very similar in appearance to sarcoidosis. And she has granulomas that were diagnosed via some mechanism unknown. It may have been a transbronchial biopsy or something, but she has granulomas in here somewhere. So, but I thought that was a nice case of presumptive berylliosis.
Wow. I've seen a few cases of nodular disease, but I've never seen one with this extensive disease and the bronchiectasis from beryllium that I've ever seen. Wow.
So presumptively that's what it is. Let me show you another one that I've never seen, this following phenomenon. Let me bring up the, let's see here. Let me make sure I have the right one. Okay, so let me just show you the lower chest in these two. This is a 27-year-old female who came in. This is her CT about 5 months ago, and I saw her 5 months ago because I put this in my teaching file. And I put it in because look at the, show you the chest wall first. Look at the costal cartilages, very, very calcified for 27. And her chest wall otherwise doesn't look too bad, just some cartilaginous calcification there. Let's go up to the trachea. There's thickening of the trachea. It somewhat spares the posterior wall. And this is a patient with polychondritis. That in itself would be interesting, but I've never seen the following phenomenon. This patient came back just a few days ago with chest pain. And here, keep in mind, this is just 5 months after that last CT. Look at the pectus deformity that has, this pectus excavatum that has developed just in that last few months. Look at the cartilage here, much more cartilage there, or looks inflamed. There's even more calcium there. This is a case of pectus excavatum that has developed just over the course of months, and a patient with polychondritis that is acting up. And she was tender in these areas, and presumably that was because of this cartilaginous inflammation. But just to show you it's the same person, here's the upper trachea. It has thickening and calcification. And so I'd never seen, let's look at the sagittal here. I'd never really seen or heard of that phenomenon, but you can see that. Apparently there are multiple case reports of pectus developing in polychondritis. Have you all ever seen that phenomenon?
No, but it's pretty freaking cool. I'm definitely going to steal it and use it in my lecture. That's pretty awesome.
Yeah, I got really. This is like one of the best cases I've had in a long time. So, but it's interesting that you can see both the inflammation of the cartilage there and also the new pectus. So but there are case reports of this. So, but anyway.
And is it just extreme weakening? Is it fracture there, or is it just malacia?
I presume it's malacia, and it's just weakening, and I don't know that I really.
Inflammation, destruction. Yeah, I mean it just destroys the cartilage. It just eats it away. I mean it's just that's fascinating.
But presumably, I mean that's just affects all the angles here of the chest wall, and so that gives you kind of results in a pectus that I wouldn't have believed this had I not seen it with my own eyes. So. Here's one other case that I wouldn't have really expected either, that I've never seen before. But here's a case. Let me show you this. So this patient is a person in his early 50s, and if you're just looking at the chest wall here, and I kind of wish David were on the call because he would want me to look at the cruce here, very thin. The cruce is very thin. And almost no normal muscle tissue, just severe fatty atrophy everywhere. And so, what would you all think about this case? What's
muscular dystrophy, myositis? steroids.
Another one of these
Inflammatory.
ALS cases.
Polio.
Yeah, some things like that. So the history is this patient, 3 months prior to this, CT had a case of West Nile virus, and this is an ascending paralysis from West Nile viral infection. And I didn't know you could get such a severe atrophy and paralysis from this, but apparently clinically it looked almost like a Guillain-Barré and kept going, and now the patient is in respiratory failure and is trached. And you can get these cases of fairly acute flaccid paralysis from West Nile infection. So this is a severe case of West Nile confirmed, infection causing paralysis and resulting muscle atrophy. So I just thought that was something, I've never seen that before. Has anyone seen that before?
No, definitely not. Wow. Wow. So spinal injury of horn cells resulting in poliomyelitis-like syndrome. I'm reading the abstract. Wow.
Right.
Wow.
So
I was right with polio. There we go.
yes. So I think I'll stop there, but a couple of cases this week I've never seen before, so I thought those were interesting.
We haven't either, that's for sure. Goodness.
Those were impressive. All right. Let's see. Seth, you want to go?
Sure. I'm going to try to top those. I think some symmetric myocardial hypertrophy, normal function. I'll show you the 4-chamber, if I can find it here. And this will probably take too long. Let's see if it will work. So here, again, hypertrophy myocardium. Now, what's really cool about this case is that the patient had a known diagnosis. I'll show you the 4-chamber delay. Sorry. And you can see this myocardium looks normal except for this portion here that corresponds to predominantly the inferolateral segment. So let me show you the, here we go, the short axis, and you can see really nice nulling of the majority of the myocardium, but then we get to this inferolateral segment at the mid-cavity and the base, and we see this mid-myocardial enhancement. When you see a myocardium this thick, there's a differential diagnosis. And when you see this pattern of enhancement, this is only the second case I've seen it, the first with this characteristic pattern of enhancement. But what really makes this case cool is we did T1 mapping. And this is a T1 mapping at 3T. And just to let people know, on our scanner, around 1,000 is normal. So this is extremely rapid relaxation of the myocardium on non-contrast T1. And there's only 2 that do this, give you rapid relaxation. One is due to metal deposition with hemochromatosis with iron deposition, and the other is due to lipoid and fat deposition due to Fabry's or Anderson-Fabry's. So this is a case, this guy had known Anderson-Fabry's, and it's really cool because it's the best case I've ever seen showing the characteristic enhancement, but also got the T1 showing the rapid relaxation due to the fatty deposition, because we know fat on MR causes more rapid relaxation than normal soft tissue and myocytes. So that was badass case 1. Which case was this? I don't remember which case this was. I'll pull it over. Let's see. Oh, this is really, really weird. Okay, so this person has a history of head and neck cancer. And this is more of a have you guys ever seen, because it's odd. Head and neck cancer that's relatively localized. They were doing a scan for initial staging, and I noticed there are these pleural nodules. They're not subtle. There are a few of them around, and they wedged one out. They took the whole thing out, and it came back as type B1 thymoma. Now, the interesting thing is that there is no thymoma. The path was pretty conclusive. They showed it on thing. They showed all the stains. And it looked like thymoma. I mean, even for all the cases of thymoma I've seen, which has been a fair amount, it looked like thymoma. I've seen a case of an ectopic pleural thymoma, that was one lesion, but this was doomed to be drop mets, but there's no primary lesion. So has anyone seen that before?
Nope, definitely not.
Nope.
That's
Yeah, so that was, I don't know how to explain that, except maybe that there was an ectopic thymoma in the pleura, because you can get, like they say, you know, small percentage are ectopic, and maybe that one started to drop metastasis. I don't know.
and there was one upper right hemithorax to a small one, bilateral, or was there higher?
Oh no, it was just on. What was it?
Not higher. Higher, right there. What was there?
Oh, this on the right.
A little bit lower. Mediastinal window. Bit lower. Well, there was a small little thing right there, and can't tell. It's
Yeah, I
can't
didn't.
tell.
But anyway, so
on the left side,
yeah, multiple thymoma without a primary. So they're trying to figure out what to do. This case was this? Oh yeah, this is a interesting case just because it's got pretty imaging findings. It's a gentleman who presented with, it's actually the second one I've seen here, strangely enough, with severe chest pain, has this very ugly pericardial effusion with thickening and enhancement of the pericardium. With this, you would be thinking of, he was initially found to have this, and on an outside study, was thought to have pericarditis, was tapped and treated, but they noticed that the tap was kind of odd, and there were malignant cells. They did a larger biopsy, and it's really, you can really see this thing extending into the transverse sinus, which is superior pericardial recess is part of, and then you can see portions of it in the oblique sinus, around the inferior pulmonary venous recess. Anyways, this was a primary pericardial epithelioid angiosarcoma. They're debating between epithelioid or hemangioendothelioma versus angiosarcoma, but it was sent to like, he's gone to like 3 different centers, and everybody has read it as primary pericardial angiosarcoma. I have a PET to go with it, and not surprisingly, the PET shows that it is hot and ugly. So another one of those. And then
Thought for sure you were going to say mesothelioma.
Well, I thought it was going to be pericardial meso. No, I thought it was going to be pericardial meso all day of the week. And that's not what it was. And there's no way for us to tell. I looked at the path reports from Sloan Kettering and whatever, MD Anderson, they all came to the same diagnosis. Now, this is an interesting case only because I've never seen this is a person who had a obliterative bronchiolitis, constrictive bronchiolitis for some unknown reason, not the important point. They got transplanted. So this is the right lung many years later. And has anyone ever seen, I mean, it looks like a minute. You know, has anyone ever seen such destruction of underlying lung vasculature in I mean, we just don't normally see these people eat. If they had their normal lungs, they'd be dead a long time ago. And usually I've seen them with transplant if I get bilateral lung transplant. I just never seen a lung be so decimated by small airways disease that literally just there is no blood, presumably no blood flow and no vasculature I mean, there's minimal amount to supply the lung. It just is so lucid. It was just fascinating pulling it up. I have nothing to say other than it's a pretty finding. It's just was striking to me. Anyway,
I'm trying to think why that right lung isn't blacker. More.
Yeah, not sure.
It's curious.
But anyways, those are my cases.
All right, thank you, Seth. Those were cool.
Abby, you didn't say anything about my Fabry's disease. Very upset.
No, I have to look it up. What that stuff is, the fatty stuff. My goodness,
yeah,
that's a good one.
Very cool. All right, Howard.
Okay. Well, this will be something that will be relatively new to us. This is kind of thing you read about in the textbooks, but maybe the first one I've seen like this, maybe ever. So this is from the outside, and you can see the history right there, which is interesting. It says lump left breast. There is a lot of abnormality in the left lung. Up here, there are maybe lucency or cavitations here in the lingular division. Opacity. Here you can see there is this lump, and this is a male, so that shouldn't be there. And then, of course, when we look at the chest, we'll see why it looks that way. So up here, there's extensive cystic disease, opacities, architectural distortion, volume loss. Now we come into a lot of opacity in the lingular division. And yes, indeed, there is extensive involvement of it, as well as the chest wall up here. So the history is, has to be really important. Apparently on the outside, I'm not sure, they at least aspirated this and got something, but I couldn't find details about what was retrieved on the aspiration of this lump that you see there. What I'm going to show you now is an interesting description of the surgical findings when they went to treat this, thinking that this was an infection, but you'll see kind of the interesting report. So you can see why this took so long to do the surgery. But look at the language here. It became more and more apparent that it represented a cancerous invasion of tumor. And over here, just look at the language, a very hard lesion, very abnormal, concerning for cancerous cells. But it isn't. And here is the path, if I can go back. And I underline that. So this is a case of actinomyces, actinomycosis. And that's kind of the classic textbook thing, as best I remember, of when you have a pneumonia that involves the chest wall. And I think it can weep and exude these things called sulfur granules or something like that. But I think it's the first case that I've seen with such extensive pneumonia and chest wall involvement by actinomyces. And here you can see that there. So that was really impressive.
So Howard, it's interesting. They mentioned the woody muscle in the operative description, and that's very typical of actinomycosis to cause extensive fibrosis, and it's really rock hard tissue.
Yeah.
It's been described in the pelvis with causing a chronic salpingitis, and it's like cement in there. And I don't know if they mention anything about the patient, but usually they have really poor dentition, and that's where this organism likes to live, besides the smell.
I see.
And a little fun fact is that smell you smell when it starts to rain is actinomyces coming out of its spore form in the soil.
Oh, yeah?
Yeah.
Wow.
That's amazing. I have one case, and maybe Seth had shown a case many years ago of one invading the chest wall, but never that extensive. But
Yeah.
you can even see the hyperostosis along the ribs that goes along with this chronic inflammatory process.
Yeah, let's have a look at that. It's pretty dramatic, isn't it?
How thick the inner cortices are.
Yeah, pretty dramatic case. Let's just look at the post-op. I'm not quite sure why they did the post-op, but I think on the post-op we just have what they were able to do. So they were able to remove quite a lot of the anterior chest wall stuff. Well, to some extent they were. Here you can see the result of that surgery, and there's still abnormality there. And I don't know what's going on there. But of course, they're hoping to treat him with big-time antimicrobials and hope that this will resolve over time and heal itself. But they basically just explored that, as you can tell from the surgery. That's pretty dramatic.
Howard, do you think it's involving the pericardium there? We were just talking about that.
No, I don't know. On that initial one, I thought that the process had extended into into fat. I don't know about pericardium. Let me see what I have from before. Sorry about this. I don't know about the pericardium, but I thought, and Leif too, thought that some of the process had just grown into the chest wall, inflammation of the fat contiguous with pericardium at least. It does look nasty here, doesn't it?
Yep.
Perhaps just very, very inflamed.
Any chance you catch the mandibular teeth on that scanogram on your little side tab there? Hard to say.
Yeah, would have to be something rather big. Yeah, I think that the surgeon is a new guy here, and I asked him, and he said, have you ever seen such a thing before? And he was kind of surprised. I mean, how many cases, even of a surgeon, do you see of actinomyces in the chest wall? This is an interesting case that's not new, but I saw it the other day for the first time. So let me show you this one. This is a scout image, so keep your eye just in general on this area. And I'll show you the history in a moment, but she developed symptoms that mostly involved swelling of her face and her neck and discomfort associated with that. So let me show you the images really fast, but I actually want to go down here first because this is kind of classic. So if you were scanning upwards and you see that and you say, oh yeah, this is the classic collateral pathway for central vein obstruction, where we have so-called veins of Sappi that connect up. This is the superior epigastric to the liver. I forget which segment this is. And then, of course, as we go up, we'll see other pathways come into play. So we have central venous obstruction. Now, if you go up here, you can see contrast medium coming in, collateral vessels, but notice that this is distended. And this should be opacified with contrast medium. It is not opacified with contrast medium. So here is the venous obstruction, but this is a young person and has obstruction in that location. I don't know the exact way she was worked up, but let me show you on a PET scan that that area up there is hot. So I don't have fused images, but right at the confluence of those veins is this right there. So she went to surgery for both diagnosis and the treatment of it. And she had an exploration. They bypassed and did a graft, I think, from the jugular vein to something else like the SVC. But this is a case on histology of a epithelioid hemangioendothelioma. So I looked for case reports of that because I've not seen that myself. And you can find many case reports of venous occlusions in different places from epithelioid hemangioendothelioma. And that's what that is. And you can see some of the work up there with lots of histology as well as immunohistochemical stains. So CD34 is a vascular cell surface thing, which was positive. And another one called ERG was positive, and that is found in vascular tumors. So putting it all together, they diagnosed this as that entity. She had radiation therapy for that, and she's actually doing okay. So this was up 2014, now we're 2017, and she's actually doing okay, no evidence of tumor recurrence. And in spite of the fact that her vascular graft occluded, she's actually doing okay, so she doesn't have symptoms. I guess her collateral pathways have just turned out to be adequate, and she's actually doing okay with that tumor. Anyone seen a venous one before? I've seen one or two cases in the chest, in the lungs, and lymph nodes and bone, but not a venous one.
Oh, wow.
Interesting, huh? All right. Let's see what this one is again. Okay, this is a really interesting patient of the case of, I'll just show you before I give you the diagnosis, but I'll show you the lesions. So there are two of them, and they both have the same features. So here is number one, left subaortic mediastinum, contrast enhancement of the lesion, quite striking. And the second one is in a peculiar location, but you can see its relationship to the left atrium, the left superior pulmonary vein in front of the aorta. So this person has two lesions like that. And this is a person with a known syndrome, which is an SDH-related syndrome, so an SDH-related mutation. So these are paragangliomas. And I don't know if other family members are affected, but I think the PET scan showed others right there. So there are multiple paragangliomas. And this is one of the SDH mutation syndromes that you see there. And the person did have surgery for the chest lesions. I think it was obviously very difficult surgery. Jeff, do you have cases to show? I can stop and I can show my others another time.
Okay, we might have time. I've got some. All righty. So I have some follow-up for you guys as soon as I get this loaded here. So remember the case of lymphangiectasia, lymphangiomatosis I showed, the crazy looking lungs, the guy who had a bunch of chyle material in his airways? Is it you?
Yeah.
So this is the lymphangiogram. And so you can follow it up here, and I'll move along. Get right here. So you'll see early on, I think this is, yeah, you can see already. So this is the thoracic duct. And you can see all these tortuous little side vessels. And then here's the run, and you can see early all these side vessels. Now watch it. It will keep going up. So here it's heading up towards the brachiocephalic vein. But notice there's all this spillage around there. And interesting, one of our interventional radiologists explained that where the thoracic duct empties into the venous system is sort of like a river delta. But they said this one was quite large. And you can see some continuation. But look at this lymphatic channel here. It goes along sort of like a pericardial margin. And here's another run. Let's see if I can get it to run here. Yeah, it doesn't. Well, there we go. So yeah, so he was refluxing. The patient was refluxing chyle into the lungs, and that's why he would present with chyloptysis. And so what you can see what they did is they coiled this. They were hoping to put a covered stent through it, which would maintain patency of the thoracic duct, but there was just too many side branches. So they actually coiled it, a large portion of it, and then later on, this is you can see this is actually glue here. So they obliterated the whole thoracic duct with the hopes of reducing his chyloptysis and shortness of breath. Of course, you can develop chylous buildup in the bowel and lower extremities, so you can get lymphedema and diarrhea, but you won't have nearly as many problems breathing. But this confirms what we suspected, that this was all lymphatic, and it's flowing into the lungs as opposed to build up in the lungs because it can't drain. So it's a retrograde reflux of chyle. Yeah.
Wow.
All right. Here is a case of, it's a good case for a couple of reasons. Let me show the CT first. But this is another case of smoke. I showed a few of you earlier. But so this patient has a squamous cell carcinoma of the right lower lobe, and you can see the mass effect on the bronchus intermedius and then the middle lower lobe bronchi. But there's this nice filling defect here. Sort of looks like a plunger or something into the left atrium. But if you do look at the ROI on this, it's extremely high. And this is just slow flow coming in from this collapsed segment. So that's an example of smoke. And here's the radiograph too, which shows that the collapse. You can see the displaced fissures on both sides. I mean, on the right there. And then here's the lateral view where you have the spine sign increased density over that, which correlates with the collapsed lung on the CT, where you see the sort of little bit of the, looks like the middle lobe is aerated here, but not much. And then the lower lobe is collapsed. So it looks like the medial segment of the middle lobe is down, as well as the left lower lobe, right lower lobe.
We read it. Yeah.
All right, this is a fun case. This case I came across as a tumor board case, and let me see if I can pull this up here. So this is a woman with a cardiac history who was noted to have a mass on her chest radiograph, and this is 2016. And if we jump ahead to 2017, oh, sorry, that's 2016, and this is 2017. So these are about a year and a half apart. And then so I don't know what the whole time frame was, but a CT was done that shows this spiculated mass in that right upper lobe, and there's a bunch of surrounding nodules, and you can see this airway goes into it and sort of stops. Now what's important, of course, is to look at it on a different window setting, and you'll see that indeed there is fat in this area of mass or consolidation. There is some soft tissue component, and there's this dystrophic calcification. And done elsewhere and correctly interpreted by the radiologists at this other institution that this was a lipoid pneumonia. But the person caring for the patient was not familiar with this entity and was worried that this was a cancer and opted to do a PET scan instead. And I can have them fused here, and you can see, of course, this is pretty hypermetabolic, so this raised a lot of alarms, and so a biopsy was done that just showed granulomatous inflammation. So it was brought to our tumor board. It was referred here for further workup or management, and so I agreed with the outside radiologist that this was a lipoid pneumonia, and our pathologists confirmed that granulomas are very common in lipoid pneumonia. And so the physician she was referred to here went and called the patient right after tumor board, and lo and behold, she'd been putting Vicks Vapor Rub in her nostrils for many, many years, especially during the winter months. And there's several case reports of these mentholatum-like vapor rubs causing lipoid pneumonia. And she does sleep on her right, so she's aspirating into her right lung. Okay.
Right lung and right upper lobe. That's curious.
Yeah.
So breaking the rules.
Yeah. So it's really it's primarily a radiologic diagnosis, or at least it suggests it. But you can see what happens is if many clinicians aren't familiar with this, and a PET scan can send people down the wrong pathway. She was referred to us for lobectomy potentially, or wedge resection, and it's not what happened, thank goodness. So it's just a lipoid pneumonia, and there's somewhat of a limited role for steroids that there's in some case reports that can obviously cessation of the offending agent, but can reduce some of the inflammation. But it can persist, it can go away. She's got quite a bit there. It's probably going to hang around. Okay, this is an interesting case. Let me start here. So this is the 11-year-old girl who has a history of a type 1 truncus arteriosus that has been repaired. She's had multiple surgeries, and she's developed stenosis at her pulmonary vein from her repair, and so they went in and put the stent here, and everything was doing well. You can see there's good flow through it. But the cardiologist, I think at the time, was also trying to optimize the flow. Here's another view of it here. You can see when they inject, you get really good flow into the pulmonary artery system. So, but they wanted to adjust it a little bit more, so they increased the pressure on the balloon. I don't have those images, but she developed hemoptysis in the operating room at the time of the surgery, and you can see there's consolidation in the upper lobe, and here's that stent, and I'll show you the CT, and these may be a little bit out of order, but it gets the point across. You can see there's the stent, but there's this collection lateral to it, and then this trail of contrast into the left lung. So unfortunately what happened was the anastomosis distally tore right here. There's the anastomosis with the pulmonary arteries from her original truncus repair, and it formed a pseudoaneurysm that ruptured into the lung. They went and repaired this yesterday and actually were able to see the tear in it directly into the communication into the lung. So they resected the pseudoaneurysm, and they buttressed and reinforced this anastomosis in there. So just a complication of a procedure that can happen with angioplasty. But you know, the part of the problem is when you've had multiple operations, there's often a lot of scarring and stuff, so it may require higher balloon pressures.
Wow.
And then another cardiovascular case here, and I'll start with the CT. So this is a 47-year-old who has two anomalies that are both very rare. So this is a congenital, let's see, make sure you can see what I'm saying. Yeah, congenital sinus of Valsalva aneurysm that we see here. And there actually is a communication. It had actually ruptured into the right ventricle, and I'll show you the cardiac MR. But in addition, there's a supracrystal ventriculoseptal defect right underneath. And they're often associated because they're formed from some of the same conal tissues. And so these are this got repaired as well. So they're gonna repair it. So they're gonna try to do a valve sparing repair, resect the aneurysm, buttress that, and close the VSD at the same time. Now let me see on the cardiac MR. Let's see, I want the short axis right here. I'll just play through it here. So what we can see is they're hard to see on the MR. They saw it on the echo a little bit better, but as we get closer to the aneurysm, we'll see a small little right there. So this little area of dephasing, that's the communication with the sinus of Valsalva aneurysm and the ventricle. And then a little, I think it's a little lower down, harder to see. You can see the, and I'll just send it around, you can look for it, but you can see the little VSD a little bit better on that one. You can also see it on the flow images. Let's see if I think I got those. I thought I grabbed them.
We had almost an identical case literally like 2 days ago. On CT.
Ruptured aneurysm?
Of a ruptured sinus of Valsalva aneurysm, and usually the aneurysm forms because it's covering up a portion of that supracrystal VSD or that outflow tract VSD. It kind of gets sucked out towards there. Anyways.
That's so cool. Yeah, you can see right there on the flow image is this little white thing that flashes. That's one of that's the shunt, and then I think you can see it right there. That's the same one, but you can sort of tease it out. But it wasn't appreciated initially on the MR, but looking at it in retrospect with the echo, which I don't have the echo, I showed that. So yeah, that's cool. But I've not seen a congenital. I've seen one congenital one before, but not with an associated VSD like this.
Yeah,
exactly. Whole staff.
Sorry, Jeff, I was going to say, Dr. Art Stillman is here, and he was talking about the fact that a lot of people have talked about the windsock mechanism of this, like Seth was saying, the jet creating a windsock-like mechanism, creating the sinus of Valsalva aneurysm. So apparently there may be some, that may be a mechanism that operates in this case.
So is it sort of like a negative pressure as there's flow across the VSD that sort of pulls on the sinus of Valsalva? Is that what you're saying?
Yeah. So the high velocity is going to decrease the pressure, and it's going to basically suck things in because it's creating a negative pressure or lower pressure. It's like the same thing you get with SAM and hypertrophic cardiomyopathy, similar kind of concept.
Okay.
But at least that's what I was taught and what I kind of always thought with those, but I don't know. Maybe there's a better explanation.
Well, that makes sense.
And then the rupture is just a random thing?
Yeah, I guess, they get weak, and it's the systemic pressures in the aortic root eventually can cause undermines the wall of the aorta, and it ruptures in there, and it's a contained rupture, so it just creates a small shunt or a big shunt, as the case may be. So, okay, well, there's a few minutes left. If anyone has another case or two, Howard or anyone.
I can show two, maybe quickly.
Okay.
First one I'm going to show is just a nice congenital one, if I can find it, that Leif told me about. So let's see if I have the right one. So this is just an observation, incidental observation, or an observation of an incidental finding in an oncology patient. So it's going down. PPI in this guy. So we have LAD. We have a nice, great cardiac vein. Tell me if I've got my terminology incorrect. And it drains into left atrium. So a great cardiac vein to left atrial congenital communication. Just a nice example of that as an incidental finding right there. There it goes. Everyone agree? Those of you that I've never seen one before, maybe I missed them.
I guess it's sort of along the variant of a left SVC draining into the left atrium, because a lot of times it's right where the great cardiac vein comes together.
All right, thanks, man.
I don't know. That's odd.
Isn't that interesting? Yeah.
Yeah, we had one, and it was just called a kind of a variant of an unroofed coronary sinus, where basically, I mean, the cardiac vein at that point is almost coming, except for the interventricular vein coming across, is basically nearly the coronary sinus, and it's just draining into the left superior pulmonary vein. Is that what it's doing? And then draining from the left superior pulmonary vein. There, yeah, by the ostium. Yeah, we've seen that before, and we've just called it like one of these unroofed coronary sinus variants, but who knows? Because does he have he has a normal SVC, right? He doesn't have.
Right,
yeah.
SVC's there.
Does he have a coronary sinus at all? A really rudimentary one.
Well, we have a small one, but I guess, is that just a manifestation of diminished blood flow through it?
Probably.
I think that's actually draining the inferior interventricular vein. That's coming across down below there. Yeah, so there's like a residual portion that's draining like a portion of that inferior interventricular vein into there, but the majority is being diverted into the left side via the defect. That's how I would read it, looking at those just those images.
Sure. Yeah, that's nice. I'm going to keep a few for next time. Let me see. Well, let me keep the other ones because I've got a couple of pair cases for another time, Jeff.
Okay, thanks. All right, everybody.
All right, guys.
Talk to you next week.
And
All right, bye.
Hey, thanks, everyone.